Usually when we talk about a clinical diagnosis, there is this underlying expectation of precision. It's almost like engineering, right?
Right, like it's very exact.
Yeah. You break your arm, the x-ray shows that jagged white line on the screen,
Mm.
and the doctor just points and says, well, there it is. It's visible, it's totally undeniable, and honestly, it's very comforting.
It's binary. I mean, the bone is broken or it isn't.
Mhm.
We just naturally gravitate toward things that we can easily see and, immediately categorize.
But then you step into the world of applied behavior analysis, and suddenly you realize that x-ray machine is just fundamentally broken. We are looking at a diagnostic and ethical landscape that is incredibly murky.
Oh, absolutely.
Because being an effective ethical behavior analyst isn't just about reading a cumulative record correctly or, knowing your reinforcement schedules.
Mhm.
It's about navigating profoundly complex, messy human situations.
Yeah, the human element changes everything.
Right. We're talking about figuring out whether accepting a home-cooked Moroccan meal violates the ethics code,
Mm.
or sitting in a living room figuring out how to handle a parent who is demanding you change their child's gender expression behaviors.
That is the absolute definition of diagnostic muddy waters. And it's exactly why the field of ABA has had to evolve its ethical standards so aggressively. I mean, we aren't operating in a sterile lab.
Right. No white coats and clipboards in a vacuum.
Exactly. We are operating in people's homes, in their cultures, and in their daily lives.
Which brings us to our core mission for today's deep dive. We are unpacking BCBA Foundation's task list item E.9, which is cultural humility and ABA practice.
It's a big one.
It really is. And for you listening, we've got a massive stack of sources on the table today, pulling from comprehensive ABA study guides, mock exams, and this really interesting book, a workbook of ethical case scenarios in applied behavior analysis.
Lots of really practical examples in that one.
Yeah, totally. And I want to pause right here at the top. If you are listening to this and you are currently in the trenches prepping for your exam, and you need more resources to help you untangle these concepts, you can access study guides, tools, and ABA resources right now at https://stan.store/therapy-services. That is https://stan.store/therapy-services.
It is an essential topic, and, not just for passing a test, but because cultural awareness is the critical linchpin for any ethical and actually effective intervention.
Okay, let's unpack this from the foundation up.
Yeah.
Because before we can even attempt to apply cultural humility in the field, we have to define what it actually means.
Right.
And here is where I get a little tripped up. Because we are talking about a science that is entirely unapologetically built on observable behavior.
Yes.
But the sources point out this fascinating irony right off the bat with BACB Code 1.07, which covers cultural responsiveness and diversity. Terms like cultural responsiveness and cultural humility, they aren't actually behavioral terms, are they?
No, they aren't. They're attitudes.
Attitude.
Yeah, which presents a real philosophical challenge for behavior analysts. Because we operate in the realm of the observable, we don't measure attitudes.
Right, can't put an attitude on a scatter plot.
Exactly. So, to make sense of this, the literature looks back to B.F. Skinner. In his book, Beyond Freedom and Dignity, Skinner defined culture not as some mystical, abstract concept, or, just the food you eat and the holidays you celebrate.
Okay, so how did he define it?
He defined culture as a set of practices and customary behaviors that are arranged by other people.
Wait, I want to make sure I'm synthesizing this correctly. Does that mean Skinner viewed culture not as a demographic checkbox like race or religion or nationality, but literally as a unique ecosystem of reinforcements?
That is exactly the shift in perspective you need. Culture is the specific set of contingencies of reinforcement that a person is exposed to within their family or their community.
Wow. So, to a pure behaviorist, culture isn't an abstract feeling. It is literally a localized data set of reinforcement histories.
Right.
That completely reframes the concept. When you ignore a client's culture, you aren't just being impolite. You are ignoring the core data of your own science.
That is a phenomenal way to look at it. And that brings us to what cultural humility actually means in a behavioral sense. It means approaching a case with the assumption that the contingencies that produced a family's behavior are genuine.
Right.
They're deeply shared by the family members, and those specific contingencies absolutely must be respected and factored in when you are conceptualizing a behavior plan.
So no copy-pasting interventions.
Exactly. You cannot use a cookie-cutter approach in ABA. You have to design a bespoke, client-centric goal that fits seamlessly into the unique environmental ecosystem of that specific family.
I love the bespoke suit analogy. But let's be real. You cannot tailor a bespoke suit if your own internal tape measure is bent.
Oh, that's a good point.
Moving from understanding the client's culture, it seems like the sources are telling us we have to first examine our own lenses. Which brings us to Code 1.10, Awareness of Personal Biases and Challenges. The text lists some very specific biases that professionals bring into the room.
Yes, the study guides highlight several pervasive ones. There is affinity bias, which is the subconscious tendency to gravitate toward people who look, think, or act like you.
That makes sense.
There's ageism. There is confirmation bias, where a practitioner only looks for behavioral data that confirms a hypothesis they've already decided is true.
Oh, that's dangerous.
Very. And they also explicitly note gender bias and weight bias, which is judging a person negatively or making clinical assumptions based on their size.
And the BACB actually requires behavior analysts to take appropriate steps to resolve these interferences, right? Like, you have to document all actions taken when personal biases or challenges interfere with your professional work.
Yes, it's a hard requirement.
But I have to push back here. If ABA is strictly about observable, measurable behavior, how are we supposed to fix an implicit bias? The text literally admits there is no effective behavioral technology for observing and measuring biased behavior yet. So how do you fix a covert behavior that you technically can't measure?
What's fascinating here is that this is the exact friction point the field is wrestling with. Because we don't have a strict behavioral technology for implicit bias yet, behavior analysts are advised to look outside our own silo.
Oh, really? To where?
We borrow strategies from other professional fields, specifically family medicine. The American Academy of Family Physicians recommends very specific, actionable steps to intervene on your own covert behaviors before they manifest as overt professional mistakes.
Okay, so what do those interventions actually look like in practice?
They involve intentionally designing your own behavioral speed bumps.
Speed bumps.
Yeah. For example, engaging in structured, intentional conversations with peers, specifically to explore and identify prejudices you might be harboring.
Wow, that takes some vulnerability.
It does. Or another one is intentionally pausing before interacting with people from certain groups to actively reduce automatic reflexive behaviors. It's about self-monitoring. You have to force yourself to take the time to actively consider the clinical experience from the point of view of the person being stereotyped.
So if we accept that our own internal tape measure is naturally biased, and we have to put these speed bumps in place, what happens to our standard assessment tools?
That's where things get really tricky.
Because we are looking at task list item F2 here, which is identifying and integrating cultural variables in the assessment process. What happens when a culturally biased practitioner uses a culturally biased tool to measure a child's behavior? You must get a completely skewed baseline.
You get an entirely invalid assessment. Integrating cultural variables changes everything about how you measure behavior. For one, it demands that you become highly critical of standardized, norm-reference tests.
You know, standardized testing in ABA is starting to sound a lot like trying to use a Mac charger on a PC. The hardware itself might be perfectly fine, but the interface just doesn't match the operating system.
That's a great analogy. Those norm reference tests are usually designed based on the behavioral values of a specific dominant cultural group.
Right, usually Western middle-class norms.
Exactly. Let's look at the example provided in the study guides. Imagine you are assessing a client's social skills. The standardized test might flag a lack of direct eye contact or speaking very softly as a social deficit or a maladaptive behavior.
Sure, because in the U.S., we value looking people in the eye.
Right. But in many cultures, avoiding direct eye contact with an adult or an authority figure is a reinforced sign of profound respect.
So what does this all mean? If a child's culture reinforces soft-spoken respect, but your assessment tool only scores loud, direct eye contact as a successful social skill, the tool is broken, not the child. We can't use the exact same definition of maladaptive behavior across every household.
You absolutely cannot. If you don't understand the cultural variables, if you don't map that specific contingency environment, you might accidentally write an intervention plan to fix a behavior that is actually highly functional and culturally appropriate for that learner's natural life.
And I imagine that deeply affects the interventions we use to reinforce behavior, too.
Exactly. Reinforcement has to be culturally aligned to be effective. For one learner, individual verbal praise like, great job in front of the class might be a highly motivating reinforcer.
Like a gold star.
Right. But for another learner from a different cultural background, being singled out for individual praise might be deeply uncomfortable or even embarrassing.
Which turns your intended reinforcer into a punisher.
Exactly. They might respond much better to a socially preferred reward, like a shared interaction that is valued by their specific community. This is why the sources stress conducting preliminary interviews with family members and sometimes even community leaders to ensure your interventions don't accidentally conflict with household beliefs.
I think we need to ground this because it all sounds very theoretical until you see the damage it causes.
Yeah, it can get bad.
To truly understand these ethical codes, we have to look at what happens when they are ignored in real clinical practice.
Hmm.
The Workbook of Ethical Case Scenarios has this gallery of clinical missteps, and I want to spend some time dissecting them, starting with the canceled considerations case.
The case of Evelyn. This one is tough to read.
It is. Evelyn made a cascade of terrible missteps across multiple cases. First, she had a client whose family primarily spoke Mandarin. And instead of securing a professional translator for the intake and goal setting, she relied on the learner's 7-year-old sister to translate everything.
Which is an incredible ethical violation. It places a completely inappropriate burden on a young child, and from a strictly clinical perspective, it guarantees you are collecting inaccurate data.
Right. Then for another client, Evelyn wrote a program goal to teach the learner to use a fork and spoon, completely ignoring the fact that the parents specifically asked her to teach the use of chopsticks first, because that's what their family uses.
She's just totally ignoring the environment.
In another case, she forced a Black learner to wash her hair daily, ignoring the parents who explicitly explained they wanted a weekly wash routine for her specific hair type.
Oh, wow.
And if that wasn't enough, she had a Jehovah's Witness learner make a birthday card during a session, even though the family requested no holiday or birthday targets be introduced.
If we connect this to the bigger picture and look at Evelyn's actions functionally, what is she actually doing to the behavioral contingencies here? Let's take the hair washing example.
Okay.
When she forces a daily wash against the family's culturally informed routine, she isn't just ignoring a preference. She is actively transforming the therapy environment into an aversive condition.
Right.
Behaviorally speaking, she is pairing herself and the entire therapy process with the punisher.
So she thinks she's just teaching hygiene, but she is actually destroying her own social validity.
Exactly. And let's look at the monolingual mess case. Chrissy, a BCBA, starts working with a new learner named Jasmine. Jasmine's family speaks Spanish at home and specifically asks for the intervention to be conducted in Spanish so the family can actively participate in the learning objectives.
Which is a very reasonable request.
Completely. Chrissy speaks Spanish herself, but she doesn't happen to have any Spanish-speaking RBTs on her current roster. So because Jasmine will eventually go to an English-speaking school, Chrissy just unilaterally decides to implement an English-only program.
She prioritized her own staffing convenience over the family's ability to be involved in the contingencies of the treatment.
Yes, exactly.
And then there's the cultural conclusions case, which deals with practitioner bias toward their own staff. Sharon, a BCBA, gets a new client whose family immigrated from China. Sharon decides to suddenly reassign one of her RBTs, Amy, to this new case purely because Amy is Asian American.
Just assuming she's a match.
Right. She assumes Amy will just naturally be a good cultural fit. But reassigning Amy forces her to change her schedule, cuts her hours, and costs her money.
When we synthesize all of these cases, what we are seeing are not just innocent, oops, I forgot mistakes. The text categorizes these as microaggressions.
And I think it's important we translate that term into the language of our science.
Mm-hmm.
Outside of ABA, people define microaggressions as brief, commonplace daily indignities. But how do we look at them behaviorally?
Think about microaggressions in terms of operant conditioning. These aren't just hurt feelings. They are intermittent, subtle punishers.
Oh, that makes so much sense.
Right. Over time, these microaggressions create a highly aversive environment that actively suppresses the family's willingness to collaborate with you. Whether they are intentional or unintentional, these intermittent punishers destroy clinical trust.
Yeah, they really do.
You cannot provide effective behavioral treatment if your baseline actions are actively alienating the stakeholders and ignoring the very ecosystem you are supposedly trying to help the learner navigate.
Here's where it gets really interesting, though. The sources do give us an example of an agency getting it right and expanding their own behavioral repertoire, the Moroccan family meals scenario.
That is a brilliant contrast. In this scenario, an in-home RBT was offered a large, beautifully prepared home-cooked lunch by a client's family who had immigrated from Morocco.
Now, any BCBA knows that the ethics code has strict, explicit rules about accepting gifts, precisely to avoid multiple relationships or conflicts of interest. Gifts generally have to be infrequent and under a $10 value.
Right, it's usually a very hard line.
But the agency learned that in Moroccan culture, refusing a meal when it is offered in a home is considered deeply offensive. It's a massive social punisher.
Exactly. To rigidly enforce a black and white no food rule would have severely damaged the therapeutic relationship. The family would have felt deeply disrespected.
So what did they do?
The agency demonstrated true cultural humility by examining their own rules. They updated their policy to allow the RBT to accept the culturally significant meal, provided the RBT documented it, and ensured the estimated value of the ingredients stayed under that $10 limit.
Wow, so they adapted their interpretation of the code to respect the localized contingencies of that culture without violating the core ethical boundary of the BACB.
Exactly. It's an incredible tightrope walk.
It really is. Which makes me think about you, the listener. If you are studying for the exam right now, this is exactly the kind of scenario that makes you second-guess yourself on a multiple-choice question. You see parents request X and client wants Y, and your brain just freezes.
It can be overwhelming.
We've seen how messy human realities get in these living rooms. But how do you translate this nuanced understanding into a passing score?
The study guides are incredibly clear on the strategy for ethics questions. When you are looking at a culturally complex scenario on the exam, there is a golden rule you must follow. Always, always prioritize the direct client's rights and well-being over the preferences of the stakeholders.
And just to clarify the tension there, the stakeholders are usually the parents, who are quite literally the ones paying the agency's bills.
Which is what makes it so difficult in practice. The text provides a highly challenging case study to illustrate this exact tension. A BCBA is working with a 10-year-old client who was born male. Over the years, the client consistently chooses female characters during pretend play, uses female avatars online, and asks to shop in the girls section for clothing.
And the parents are deeply uncomfortable with this. They're sitting in the living room asking the behavior analysts to implement interventions to stop these gender expression behaviors.
Right. The parents are asking the BCBA to use behavioral contingencies to shape the child into a non-preferred gender role.
Man, I could imagine a young BCBA sitting in that living room, sweating. The parents are the ones paying your agency. They're sitting right in front of you demanding this intervention, and you have to look them in the eye and figure out what to do.
It's incredibly stressful.
It takes an immense amount of professional courage. So if you're sitting for the test and get a question about a culturally tricky, emotionally charged situation like this, what is the ultimate cheat code for finding the right answer?
This raises an important question because the cheat code is looking for the answer that relies entirely on scientific evidence, seeks outside consultation if the issue is out of your scope, and above all, puts the direct client's well-being first.
Okay.
In the case of the 10-year-old, the ethical BCBA must refuse the parent's request.
Because implementing that plan violates the ultimate principle of do no harm.
Exactly. The BCBA must explain to the parents that intervening to suppress the child's gender expression is not supported by evidence-based practice and would actively harm the client's well-being.
Wow.
The child's right to self-determination completely trumps the parent's discomfort. If the parents insist and refuse to drop the request, the behavior analyst might ultimately have to transition the client to another provider, but they absolutely cannot ethically implement the requested intervention.
It really highlights how cultural humility isn't just a passive state of being polite. It requires active courage. You have to be willing to have very difficult conversations and advocate for the vulnerable individual in the room, even when it puts you directly at odds with the adults holding the checkbook.
It's about recognizing that the natural environment we talk so much about in ABA is entirely built out of cultural variables. If you ignore the culture, you are ignoring the environment. And if you ignore the environment, you aren't practicing behavior analysis.
So to wrap all of this up, cultural humility in ABA practice is not just a corporate buzzword. It is the ethical backbone of effective assessment. It is how we ensure our interventions aren't accidentally operating as punishers, and it is how we maintain a learner's dignity in a science that is fundamentally about changing human behavior.
Beautifully said.
And a quick reminder, if you want to dive deeper into these ethical scenarios or you are looking for tools to help you navigate these exact kinds of tricky exam questions, Definitely check out the resources at https://stand.store/therapy-services.
It is an invaluable resource for taking these high-level ethical concepts and putting them into actual testable practice.
Before we sign off, I want to leave you with a final thought to mull over. We talked at the beginning about how diagnosing behavior isn't like looking at a clean binary X-ray of a broken arm. It is more like tailoring a bespoke suit.
Right.
But right now, applied behavior analysis is expanding rapidly across the globe. It is moving out of a predominantly Western-centric framework and interacting with thousands of entirely different cultural contexts and reinforcement ecosystems worldwide.
Which is an incredible opportunity for the science, but a massive ethical challenge for the practitioners.
Exactly. So as ABA goes truly global, how will the very definition of a socially significant behavior have to evolve? When the baseline for what is considered normal or appropriate shifts entirely depending on the hemisphere you're in, will the ABA of the future look so bespoke, so uniquely tailored to its specific localized environment, that it looks entirely different depending on the country it's practiced in? Something to think about next time you pick up your behavioral measuring tape.